So hello, everybody, and welcome to the inaugural Cardiometabolic Forum, or CMF, a monthly podcast. My name's David Wheeler, and I'm Professor of Kidney Medicine at University College London and an honorary consultant nephrologist at the Royal Free Hospital. And I'm joined today by Professor Alan Jardine, who's Emeritus Professor of Renal Medicine at the University of Glasgow. Alan.
The CMF is brand new, a free educational resource for clinicians, and this podcast aims to keep you up to date with the latest information and data in the field of cardiometabolic diseases. In this episode, we'll be going through two papers published in November 2021 that we at the CMF think you'll be particularly interested in and will find useful. The first, by David and his colleagues, provides data from a pre-specified analysis of the DAPA-CKD Phase 3 clinical trial. This analysis aimed to assess the efficacy and safety of dapagliflozin in a small subgroup of the DAPA-CKD participants who had focal glomerulosclerosis, or FSGS. The primary endpoint of this analysis was a sustained decline in eGFR of more than 50%, end-stage kidney disease, or kidney or cardiovascular death.
And in the second paper today, Young et al. Performed a post-hoc analysis of the CANVAS clinical trial program. Now, this was the cardiovascular outcome trial, the safety studies of canagliflozin. And their aim in this post-hoc analysis was to determine whether canagliflozin had different cardiovascular and renal protective effect depending on the severity of the patient's diabetes. They also helped to address the problem of how do you define severity of diabetes, and we'll talk about that in just a minute.
Well, David, you'll know this study well, so could you just maybe talk us through the main points?
Of course, Alan. So the DAPA-CKD trial was a trial of dapagliflozin, an SGLT2 inhibitor that recruited patients who had chronic kidney disease. Now, the unique feature of this trial was not only did it recruit patients with diabetic kidney disease, this is a diabetes drug, but also recruited patients who had chronic kidney disease due to causes other than diabetes. And one of the subgroups of participants in the trial had this glomerular disease we know as focal segmental glomerulosclerosis. Now, the trial overall demonstrated a benefit of dapagliflozin over placebo on a variety of kidney and cardiovascular outcomes and reduced total mortality. And what we wanted to do in this pre-specified analysis was to see whether these benefits were consistent in smaller groups of patients who had specific kidney diseases. So we took the primary outcome of the trial, which was a sustained greater than or equal to 40% decline in eGFR, the onset of end-stage kidney disease, and death from kidney or cardiovascular causes. And we looked at this outcome in a subgroup of patients who had focal segmental glomerulosclerosis. Now, there's 104 patients in this subgroup analysis, and these are the patients who had biopsy-confirmed FSGS. We had a few patients labeled as having FSGS without a biopsy, but we're looking in this analysis predominantly at patients who had the biopsy confirmation of their kidney diagnosis. And what you see in the graph here is that the primary outcome was reduced in those patients randomized to dapagliflozin with FSGS compared to those who are randomized to placebo. You see that for the full study population at the bottom of the graph. You see that for a subgroup of patients with glomerular disease in the middle, and above that in the blue box, you see this primary outcome for patients with FSGS. So fewer primary endpoint results in those patients with FSGS randomized to dapagliflozin compared to those with FSGS randomized to placebo. Now, the numbers are small here, and this difference isn't actually statistically significant for this subpopulation, but as you can see, the data are consistent with the study data overall. Now, one of the problems of trials in FSGS patients is that these patients are relatively rare and the outcomes are relatively few. So what we wanted to do was to look at eGFR decline as a surrogate for kidney endpoints. And we did that in this analysis. And we showed that in the FSGS subgroup, there was a slower decline of eGFR in those randomized to dapagliflozin as compared to those randomized to placebo. Now, again, these are small numbers. Again, this is not statistically significant, but it does suggest that the eGFR decline can be used as a surrogate for the endpoint of end-stage kidney disease and kidney failure in this small population. So overall, taking patients with focal segmental glomerulosclerosis, it would seem that randomization to dapagliflozin could be a benefit. I should add that all these patients were already on ACEs or ARBs, so this is SGLT2 inhibitor on top of ACE or ARB therapy.
So it would be quite useful to look at the slope data here, because I think that gives you a real insight into the mechanism.
So because we had few clinical outcomes in this group, we looked at the impact of randomization to dapagliflozin on eGFR slope over time, so the decline of kidney function during the duration of the study. Now, when you start patients on dapagliflozin, there's an acute drop in eGFR, and we saw this in the FSGS group. But after that acute drop, the rate of decline of kidney function in FSGS patients randomized to dapagliflozin was 2 mils per minute per year slower than in those randomized to placebo. So randomization to dapagliflozin led to a slower decline in eGFR over time compared to randomization to placebo. Looking at adverse events, there were similar numbers of adverse events in the FSGS patients randomized to dapagliflozin or placebo, but there were actually fewer serious adverse events in those randomized to dapagliflozin.
So I think in the discussion of the paper, you say that this would buy maybe 8 years of time to end-stage renal failure for the sort of patients that you were recruiting at the outset. Was that true in the other subgroup analyses, or is it unique to FSGS?
No, it's similar in the other subgroups. So if we take the group we recruited with FSGS, mean age of 54, starting mean eGFR of 42 mil per minute. So this is a group of patients with fairly well preserved or reasonably well preserved kidney function. And you're not going to get a lot of dialysis endpoint events in this patient population. But we saw this same pattern in the trial population overall and in other subgroups in the trial. And we have done an analysis of the participants who went into the trial with IgA nephropathy. There were 270 of those patients. We actually saw a significant reduction in the primary endpoint in the IgA nephropathy subgroup, but also this slower decline in eGFR over time that we've also shown in the FSGS patients.
So it looks as though, obviously it's very difficult in patients with relatively rare primary renal diseases, but it looks as though there's nothing or no reason to suggest that FSGS responds any differently to dapagliflozin.
No, and I think that's our message. You know, we've been criticized for not properly defining the FSGS subgroup, and you'll know that, and it says on the slide here that this is a heterogeneous condition. Some cases are primary, underlying genetics, some cases are secondary, and we didn't do that detailed analysis of the subgroups. We just took the patients as we just took the diagnosis as reported by the investigators. So if the investigator said it was FSGS, it's FSGS in the study. So that we could be criticized for that. And of course, there are probably many different diseases, even within this rare disease subgroup.
It's fair to say that there's no treatment for it, though. That's certainly not that's been proven. So here's finally something that might slow the decline of renal function.
There is no licensed pharmacological agent for this disease, and the trials have been difficult because of this problem with slow decline of eGFR and relative rarity of hard endpoints, which of course the regulators want when it comes to licensing medications.
So the graph or figure 2 looks very like some of the data that we're familiar with ACE inhibitors, where the more profound the drop at the outset, the better renal protective effects. You discuss the potential mechanisms in the discussion part of the paper. Could you just go over those for the listeners?
Yeah, absolutely. So we're trying to protect kidney function. You give a drug and there's a sharp drop in EGFR. There's a decline in kidney function when you start the drug, and that can be problematic. And if you check a blood after 2 to 4 weeks, you might find the kidney function is worse than when you started, and you might wonder whether you've done the patient any favors. We think what's happening both with, and of course that happens with ACEs and ARBs, and we think what's happening with ACEs and ARBs and with SGLT2s is that there is acute reduction in the pressure within the glomeruli in the kidney when you start the drug. So this is like reducing the blood pressure, but reducing the blood pressure specifically within the glomerulus. Now, in the short term, that leads to a drop in filtration, but in the longer term, that glomerulus is working at a lower pressure and is therefore protected for longer from injury. So we see this with ACEs and ARBs. We've got used to it. Remember that the patients in this study were already on ACEs and ARBs, and we get an additional drop in EGFR when we start the SGLT2 inhibitor. And in the long term, as I say, that translates into a slower rate of decline of EGFR. We saw no increased risk of acute kidney injury in this trial, and this has been consistent across the SGLT2 inhibitor studies. So we don't seem to be causing harm despite this initial reduction in EGFR. In terms of mechanisms, it's all within the glomerulus. The ACEs and ARBs dilate the outflow from the glomerulus. The SGLT2s probably constrict the inflow, and both of those changes result in the reduction in the pressure within the glomerulus.
Well, they seem to be very effectively ACE inhibited or ARB treated prior to them. The blood pressure control is really very good. 127/76. That was a kind of entry blood pressure. So it's got to be something on top of circulating renal angiotensin system.
Yeah, and because ACEs and ARBs are a standard of care in this population, we wanted to recruit a group who were already on best care, and that included good blood pressure control. And I think it's a tribute to the investigators, who recruited their patients as to how well these patients were being managed, at entry into the trial, and also how well they were managed during the study.
And the proteinuria drop as well. Did you have data on the acute reduction in proteinuria?
Yeah, we've got an acute reduction in albuminuria at 2 weeks. We collected a urine and blood sample at 2 weeks into the study. It's around about a 30% reduction in albuminuria. It's actually more marked in the diabetic subgroup than the non-diabetic patients who went into the study, but the same pattern is seen in both the groups. So again, consistent with a reduction in intraglomerular pressure.
And do you think from clinical practice, then when we started off with ACE inhibitors, there was, recheck the renal function in 2 weeks, and there was a kind of panic where people would stop ACE inhibitors and then, really deny the patients the long-term benefits. Do you think there's a risk that will happen with SGLT2s, or we've got used to that kind of thing now?
Well, I think there is a risk. And in fact, a number of experts are actually suggesting that we don't check a blood sample 2 weeks after starting an SGLT2, that we wait for the normal time intervals, 3 to 4 months, 6 months before we recheck. And that is for that very reason, that, knowing the EGFR has declined might lead to discontinuation of a drug that we strongly believe from these data in the longer term is of benefit to the patient. So it may be better not to measure that 2 week, 4 week EGFR, and just to wait for the normal time interval. But yeah, we did worry about ACEs and ARBs, and we probably started using ACEs and ARBs in rather high doses, and got our fingers burnt, and I think hopefully we won't be doing that again.
And with regard to, how clinicians might use this drug on the basis of this study and the larger study that came from, the recruitment was based on, I think, an EGFR of 25 to 75. Is, the data are strong enough that we can recommend the use of dapagliflozin in patients with that level of renal function?
Yeah, so I mean, eGFR is 25 to 75 with albuminuria on ACE or ARBs. There were a few exclusions. We excluded polycystic kidney disease. We excluded type 1 diabetes, and there's an increased risk of diabetic ketoacidosis. So we should be careful with type 1 diabetics, not prescribe this drug as nephrologists to type 1 diabetics. And we also excluded patients on heavy doses of immunosuppressive therapy. But for other patients, including patients, like these who have FSGS on ACE and ARBs not on immunosuppression, then SGLT2 inhibitors seem a very sensible option based on the data in these patients who do not necessarily have type 2 diabetes. And the same with IgA and other types of glomerular disease.
Okay. Are there any other points you wanted to get over from this study?
No, I think we've covered the main points, Alan. As I say, we're not claiming this is a well-defined group of patients with FSGS. We're just saying that you're probably going to have some FSGS patients in your clinic who are being followed up, who are on ACEs and ARBs. They've probably got good blood pressure control. It's worth offering them an SGLT2 inhibitor such as dapagliflozin for added kidney protection. I probably should just add that there was no hypoglycemia and no diabetic ketoacidosis in any of the non-diabetic patients who went into this study. And as I say, the risk of AKI is reduced. So I don't think there's dangers there that we haven't uncovered in the trial.
I should have picked up on that. I mean, that is a really important take-home message. And this is a safe and effective treatment, and not just in FSGS, but in the larger body of patients with progressive primary renal disease. So, time to move on to the second paper, I think.
So we're going back a little bit in the story of SGLT2 inhibitors to the CANVAS program. And as I said at the beginning, this was the cardiovascular safety trial, or safety trials, I should say, of canagliflozin. Now, remember that all diabetes drugs coming to the market have to go through these cardiovascular safety trials. The regulators mandate these studies, and that's because we've had our fingers burnt with diabetes drugs in the past. And you may remember going back to the thiazolidinediones, which seem to increase the risk of heart failure and possibly myocardial infarction after they've been started. So regulators require that new diabetes drugs go through cardiovascular outcome trials. So these were two trials in one, the CANVAS program, and this is a post-hoc analysis of the CANVAS program of trials. So these were patients with type 2 diabetes. A few had kidney disease, but most of them didn't. And they were randomized to canagliflozin in one of two doses, 300 or 100 milligrams, or to placebo. And for most of the analyses that have come out, the two canagliflozin arms have been combined. So this is an analysis by Young and colleagues. And the question that's being asked here is, did the severity of the diabetes matter in terms of the clinical outcomes of the study? So did those patients perhaps with more severe diabetes benefit more or benefit less? And the first problem these investigators had was to sort of define how you measure intensity of diabetes. And there is no universal definition. They used three measures. They used the disease duration, so how much diabetes, how many years diabetes there'd been before the patient went into the study, the HbA1c at baseline as patients went into the study, and thirdly, the number of therapies that patients were on. And what they did in this analysis was looked at the primary outcome for the study and the secondary outcomes. So the primary outcome is a MACE outcome, major adverse cardiovascular events. So these are the atherosclerotic events. This is what the regulators required from the study. But there were also some secondary analyses in the CANVAS program that also looked at kidney events. And one of the secondary outcomes was 40% decline in eGFR, end-stage kidney disease, or death due to kidney disease. So a secondary endpoint that captures kidney outcomes. And what the investigators did was they looked at these outcomes in patients according to their baseline diabetes severity using the criteria that I've just mentioned. And the bottom line is they found really no difference in the primary or secondary outcomes when they stratified the data by the baseline severity of diabetes, however they measured that baseline severity. So, you might expect patients with more severe diabetes to benefit more from this drug, but they don't seem to. The benefits were still seen in patients with shorter duration of diabetes, who are on less therapies for diabetes, and who had HbA1cs that were closer to normal at baseline. And that kind of, I guess, goes along with the topic we've just been talking about, that these drugs actually have benefits over and above their functions as HbA1c lowering drugs. They have benefits beyond their role as diabetes drugs. I think the illustration here is probably useful to look at. This shows that the hazard ratio for the primary outcome, according to the baseline level of HbA1c, and you'll see here, although the line's a little bit wiggly, the benefit is pretty consistent. So the benefit in terms of the MACE is pretty consistent across the different levels of HbA1c. There's no suggestion that at higher levels of HbA1c, i.e. worse diabetic control going into the trial, there was a greater benefit of the drug on the outcomes. So canagliflozin has cardiovascular and kidney benefits in patients with type 2 diabetes. These benefits were present regardless of the severity of the diabetes as patients went into the study.
I mean, the impact of canagliflozin in this population is very impressive, isn't it? I mean, the reduction in MACE was, I think, 14%. The hazard ratio is 0.86. The reduction in the combined renal endpoint was 40%. And the hazard ratio is 0.6. I can't remember precisely the entrance level of renal function. But
the mean EGFR I can remember was within the normal range. It's within the vast majority of these patients did not have chronic kidney disease going into the study, and most of them had an EGFR that was normal.
Okay, but the EGFR did go down to 30 or thereabouts, did it?
Yeah, the inclusion criteria cut off patients with EGFRs of less than 30. There were actually not that many patients with chronic kidney disease going into this study, and so this wasn't really a kidney study as such, but there were some patients who obviously progressed into kidney disease or who had mild kidney disease at the beginning and developed worse kidney disease during the study. But it's a small proportion of the total patient population. So
the take-home message here is that regardless of the hemoglobin A1 on treatment, regardless of the duration of diabetes, regardless of whether or not you're on oral therapy or oral therapy plus insulin for type 2 diabetes, the cardiovascular and renal benefits appear to be similar. So
yeah, absolutely. We should remember, Alan, that there was a subsequent trial called Credence, which took patients with the combination of diabetes and chronic kidney disease and showed similar benefits on MACE, on heart failure hospitalization, and on progression of kidney disease.
So again, this is very much like the ACE inhibitor story, isn't it? It's almost as though once you've got someone with diabetes, you need to treat them and forget almost about the mechanism. So ACE inhibitors appear to have benefits that were above and beyond their blood pressure lowering. These agents appear to have benefits that are above and beyond their impacts on hemoglobin A1. Is that fair?
Well, I think so. I mean, I think, if you've got a diabetes patient in front of you and you're going to use a drug to treat the diabetes, you normally think about a drug that lowers HbA1c. And in patients with normal kidney function, SGLT2 inhibitors do lower HbA1c. So they do that job. But they do far more than that. They've got these cardiorenal benefits that we see. And we actually see those down to lower levels of EGFR, where where these drugs don't actually lower HbA1c. So below an eGFR of 45, SGLT2 inhibitors don't really have an impact on HbA1c. So if you're going to choose a diabetes drug, why not choose a drug that has these organ benefits as compared to a drug that has not been proven to have these organ preserving benefits? So I would make a strong case for arguing that, you know, diabetics should be started early on SGLT2 inhibitors to protect kidneys and hearts, as well as to control the diabetes.
Has that made it to guidelines yet?
It's in the kidney guidelines. So the KDIGO guidelines on the management of the diabetic patient with chronic kidney disease have escalated SGLT2 inhibitors to first-line therapy alongside metformin.
Okay, well, that's an important message for those people listening to this podcast. I was on the MHRA when they first reviewed SGLT2 inhibitors, and I think the pharmaceutical companies were dragged screaming to do cardiovascular outcome trials, and yet the benefits have been absolutely enormous.
Yep.
You know, it was, as you said at the beginning, because of the experience with TZDs, but I don't think anyone could have foreseen this.
Yeah, well, this, you know, the Canvas program was designed to show that these drugs were not dangerous from a cardiovascular perspective. And what did we get? We got an unexpected cardiovascular benefit. And that has led to, you know, opened up a whole new therapeutic area. So these drugs are being used in heart failure now without diabetes, and of course now in kidney failure without diabetes.
And unlike the ACE inhibitors, the knock-on benefits and cardiovascular outcomes seems to be, you know, obvious. You know, I think with ACE inhibitors and ARBs, whilst the renal protection was easy to see, the cardiovascular protection was much more difficult to, you know, tease
out of the studies. Even in a meta-analysis, it was difficult to tease out the cardiovascular benefits. So the cardiovascular benefits have been apparent in the individual trials of the SGLT2 inhibitors, particularly for heart failure, not so much for MACE. And I think this is a drug for more structural heart disease than for atherosclerotic heart disease. Having said that, you know, there were MACE benefits in some of the SGLT2 inhibitor cardiovascular outcome trials, but not in all of them. So the MACE benefit has been slightly more difficult to demonstrate.
I think the canagliflozin trials used, or one of the cardiovascular endpoints was admissions for heart failure. That seems to be an important component. Is that fair?
So yes, so these drugs seem to have an impact on heart failure. So there were 4 cardiovascular outcome trials for the 4 first to market SGLT2 inhibitors, and all those trials showed benefits on hospitalization for heart failure. And we also saw those benefits in the Credence trial, which was the trial of canagliflozin in patients with type 2 diabetes and CKD. There's been a DAPA heart failure study. There's been a DAPA-CKD study that we talked about that showed reductions in heart failure hospitalization. And there are studies of empagliflozin that have shown benefits on heart failure, even in patients with preserved ejection fraction. So the first therapy to work in patients who have heart failure with preserved ejection fraction.
Hopefully we'll be able to cover that in a subsequent podcast. So is there anything else you'd like to say today?
No, I think we've covered the topic. We've gone a lot wider than the 2 trials we started with, but I've really enjoyed talking to you, Alan, and catching up.
I've enjoyed this too. Well, thank you very much for joining today's podcast. If you'd like to access the summary slides and the papers we've discussed today, visit Cardiometabolic Forum, all one word, .com. See you next time.